Perfect. Good morning. So I'm very excited to be here this morning and to talk to you about the use of contact lenses for ocular surface disease. I don't have any financial disclosures to report. So I'm going to talk a little bit first about soft bandage contact lenses, as they have largely replaced pressure patch as standard of care for treating patients with epithelial defects. With the use of silicone hydrogel lenses, as you know, we have great oxygen permeability. So they're great options for patients that have injuries, ocular surface disease, and we often use them post-surgically. We use them extended wear for various periods of time, and it's often used in conjunction with typically topical antibiotics, but sometimes other medications as well as topical lubricants. So the benefits of bandage contact lenses is that we're able to maintain visual function while we're treating these patients, that we can treat the patient pretty easily with medications. We can easily observe and monitor the cornea for healing, and the lenses can be worn extended wear, and we can very easily remove them should complications arise. So there are a number of indications for soft bandage contact lenses, including non-infectious epithelial defects, corneal abrasions, erosions, bullous keratopathy, neurotrophic breakdowns, as well as a number of post-surgical indications, after refractive surgery, after foreign body removal, where we disrupt the epithelium, and after glaucoma filtration surgeries in some cases. We use them for filamentary keratitis. The large diameter soft lenses, I think, are a great option in mitigating patient symptoms in those cases of superior limbic keratitis, as well as various eyelid disorders where we use the lenses for protection of the cornea. We don't obviously want to use bandage contact lenses in those cases of infectious keratitis, as we just learned. We want to remove those lenses immediately. Contact lens related keratitis, severe ocular surface disease, when those patients have, when they're just bone dry and they don't have enough lubrication in the eye to support a soft lens, I think it's very dangerous, particularly over the long term, to utilize a bandage contact lens. And in those patients that we are concerned about potential follow-up. We don't want to put a soft bandage lens, obviously, in a patient's eye that may not come back to their follow-up appointments. So there are a few different FDA-approved contact lenses for bandage contact lens. The AirOptics Night and Day is one I utilize very often, as well as the AccuView Oasis, and those both have two base curves that are FDA-approved. Interestingly, the Pure Vision contact lens, only the 8.6, is actually FDA approved for the soft bandage contact lens use. So now I'm going to switch gears a little bit and switch from the soft lenses to rigid gas permeable contact lenses in the use of ocular surface disease. So I really am excited to talk to you all about PROS treatment, as it is one of my areas of expertise and one of my passions in utilizing to help patients with severe ocular surface disease. So PROS stands for prosthetic replacement of the ocular surface ecosystem, which is why we simply refer to it as PROS. It serves to restore vision, support healing, reduce patient symptoms, and dramatically improves, in many cases, patients' quality of life. These are FDA custom designed and fabricated prosthetic devices. And the design of these lenses is that they create a new smooth optical surface, and there's this expanded tear reservoir that is between the lens and the cornea to provide necessary lubrication, all while being able to provide adequate oxygen to the eye. The unique thing about PROS devices is that the design of them utilizes the spline function. So we can manipulate any of the points to create a good contour or alignment to the globe. In addition, the PROS device is unique because it is able to be cut into 8 different meridians, which can easily be manipulated irrespective of the other meridians. So this is a great option in patients with very irregular scleras or conjunctiva, particularly those patients with pinguecula, maybe temporal or nasal, where you need to have a different contour of the lens in that area so as to not create compression and cause a pinguiculitis. Also, these PROS devices use the spline function to control the vault um, without changing the base curve. And so this makes it a great option in using for patients who have advanced corneal ectasias who also have ocular surface disease, because you're able to vault pretty much any cornea. So there are a number of ocular surface disease indications for PROS, and as we know, we use PROS or scleral lenses for the treatment of dry eye, particularly those that are associated with autoimmune conditions that tend to be more severe, like graft versus host, Sjogren's, status post LASIK, just to name a few. In addition, those patients with neurotrophic corneas from various etiologies, including past herpetic infections. I use these lenses often in patients with corneal stem cell deficiency, as we see a number of patients with SJS, chemical and thermal burns, MMP, as well as aniridia at Wilmer. I also have at least a handful of patients that have done remarkably well with PROS devices that have ectodermal dysplasia. It really improves their quality of life and activities of daily living. We use these lenses in patients with lag ophthalmos from various reasons to be able to protect the cornea and keep the epithelium intact, as well as to heal persistent epithelial defects. There was a retrospective chart review that was published in the AJO in 2000 of 49 patients and 76 eyes. As you can see, there's a number of different diagnoses associated with these, but the majority was Stevens-Johnson syndrome. The mean follow-up is 33.6 months, and they use the scleral lens for daily wear in these patients. 53% of the eyes had improvement of 2 lines of best corrected visual acuity. 8 out of 15 eyes with active corneal epithelial defects healed. And remarkably, 92% of patients improved in their quality of life, including reduction in photophobia as well as discomfort. This is a photo of an eye that presented with vision of count fingers at 2 feet, which improved to 20/60. So this can be a great option for patients and really helps them to improve their quality of life as we improve their vision. This is a case of a 60-year-old female who underwent blepharoplasty, and she subsequently developed a lid retraction on the left eye, so she had an additional procedure, which unfortunately resulted in lag ophthalmos, and as you can see, severe exposure keratitis. This patient, as you can see, has really dense punctate epithelial erosions. And this is at the time of presentation. After insertion of a PROS device, 4.5 hours later with removal, you can see that the epithelial cells really recovered fantastic. And the patient is quite pleased with not only vision, but comfort. This is a patient of mine that is, we utilize PROS devices to heal persistent epithelial defect. It's a 49-year-old Caucasian male who has a history of SJS, and he has very typical presentation of keratinized lid margins, just severe ocular surface disease, and shortened fornices. He unfortunately had penetrating keratoplasty 3 times in the left eye, which led to perforation and a prosthesis. However, in the right eye, he also had a number of penetrating keratoplasties, and the most recent one was 3 months prior as a cytonic graft because of perforation. And this patient developed, again, a persistent epithelial defect. It was not healing with lubrication and Bandage soft contact lenses. So this is the patient's eye at the time of presentation. Vision was 2100. And as you can see, as you can see in the center there is a pretty large epithelial defect taking up sodium fluorescein. And so, as I said, we decided to use the PROS device for extended wear in this patient to heal the epithelial defect. So what I typically do is instill a drop of moxifloxacin in the reservoir of the PROS device and then top it off with saline, insert it on the patient's eye and have them wear it extended wear. And I follow them daily in the clinic. I remove the lens daily, clean it, evaluate the cornea, and then typically reinsert the lens. This defect improved actually after only 4 days. It was fully resolved. So here is day one, the sodium fluorescein staining. Day two, you can see it looks remarkably smaller. Day three, there's a little bit of pooling, so it's not exactly a good picture to show that we were getting additional improvement. And by day four, it's pretty well fully epithelialized, which is just amazing. And here is day 5. And I'm going to leave you with a retrospective review that was published in Cornea in 2007, actually by Debbie Jacobs, who's going to be following me, and Perry Rosenthal. And this is a retrospective review of 33 patients. And they evaluated the patient's symptoms, their quality of life, and their activities of daily living. And these patients all noted decrease in their ocular pain, reduction in photophobia, and improvement in quality of life. And these are all chronic graft versus host patients treated with PROS devices. And as we all know, that these patients can be very difficult to manage sometimes because their surfaces are just so poor. As a matter of fact, that study showed that over 90% of the patients had reduction in pain, improvement in photophobia, improvement in quality of life, and improvement in activities of daily living, including driving and reading. There were no cases of infectious keratitis reported in that study. So I think this lecture should serve to remind everyone that bandage lenses, not only soft, but also scleral lenses and PROS devices, are a great treatment modality for patients with severe ocular surface disease. Thank you.